Hi, my name is Dr. Matthew Sumikad, and I'm an emergency medicine physician working in New Jersey. I wanted to make this channel what we do in the ER because over my last 6 years, I've seen a really big disconnect between what the patients are looking for in the ER and what the physicians are doing and also looking for in the ER. And that disconnect has led to dissatisfaction on both ends. So I wanted to make this video series in order to try to bridge that gap and bring us a little bit closer together, and so we're on the same page about what we're doing and what we're looking for in the ER. Some of the common things I wanted to talk about are some of the common complaints in the ER and how we work them up. What are the dangerous things? What are the emergencies that we're looking for? And this video today is going to be about why the wait times are so long, because that's a common question I get all the time. Patients are very frustrated with it, and we as well are frustrated at being the ones working in that environment. The problem obviously is multifactorial, but I think there's really a few big components that we can talk about why the wait times are so long that might open your eyes to what the reality is on my perspective of working in the ER. Average wait times in the US are going to be about 3 hours, and for the most part, that's really only increased over the last 5 years. The patient volume has increased about 15% since COVID, and I really only expect it to go up as the ER is becoming like more of a foothold for patients who don't have primary care providers, which is unfortunately just a growing population. So, what's going on? Why is the wait time so long? The first step is really about the triage situation, right? You might not actually be having a true emergency, which is why you might have to wait. When patients come into the ER, their complaint is kind of evaluated by the triage nurse who grades them on a scale from 1 to 5. 1 is you're having a life-threatening medical emergency. Often these patients are brought in by ambulance, so they really just kind of skip over the waiting room, and those patients get brought in and they're seen right away. 5 is you need a medication refill, or you stubbed your toe a week ago, very minor complaints that pretty much do not require emergent evaluation. Most patients will pretty much fall between 1 and 3. 4 is less common, but 3 is kind of the big bulk of where people usually end up with their common complaints. A level 3 patient is someone where they have a complaint that needs evaluation, but it's not at this time maybe a medical or true emergency, maybe they have normal vital signs, and maybe they're overall well-appearing. How someone ends up being a 3 versus a 2 versus a 4 often can be a little bit of provider dependent, depending on who the triage nurse is and maybe how experienced they are or the nature of the complaint. When someone's triaged as a level 3, unfortunately, this is the big bulk of where patients end up becoming triaged, and they just have to wait. The BRs are very busy, and we can only see so many patients in a certain amount of time safely. The second point I kind of alluded to already is that volumes are very high. ER volumes are going up all the time, and a lot of this is as a result of patients lacking good primary care, and as well because primary care offices are often overwhelmed with patient complaints, and people are often referred to the ER for evaluation when they really may not be having a true emergency. I have many examples of this where a patient has an episode of abdominal pain, they call their GI doctor, and the person answering the phone might be a secretary, it might not, likely is usually not a physician, usually tells them, if you're having complaints, you should go to the ER to get evaluated. They're not really evaluating you over the phone. They're not really able to. And unfortunately, from a medical legal standpoint, referring to the ER is their safest option to protect themselves and to ensure the safety of the patient that's calling. The third facet that I think really is a key component into why the ER wait times are so long is that things take time in medicine. I think in the modern age, we're really used to instant gratification. You can order something and it comes tomorrow. You can get a test and it's done right away. Answers happen immediately. And this has led to what one of my colleagues often refers to as the mindset of Amazon Prime medicine, where people want instant answers, instant gratification. You have a pain, we want to know what it is. You have a problem, we have to find the answer. And unfortunately, medicine really just doesn't work that way. Tests take a long time. If you order blood work, it's going to take around 1 hour, usually a little bit more, in order for those results to come in. And that's just from the time the lab receives it to when the result pops up on the computer. There can be delays on both ends of that, with the nursing shortages across the country leading to delays in terms of getting the blood work drawn, getting the blood work sent, and then delays from the lab aspect where they're overwhelmed by this volume as well. They cannot run all the blood tests all at the same time. Things are often done in batches, so results will come in batches as well. The next point is that those results end up popping up on the computer, and they have to be viewed by me. They have to be evaluated by me, and I have to try to understand the clinical context that's going on about whether these results are meaningful or not meaningful. It's not so simple as, oh, look at these things and whether or not they're abnormal. It's, do these abnormalities actually require intervention? Are they meaningful abnormalities? And are they clinically relevant in this context? So there is some thought process behind it. It's not just checking off, numbers, because patients will often ask when they look at their own blood work, is this slightly abnormal result meaningful? And unless I believe it is so, I won't generally be acting upon it because they're not significant, or they could be as a result of variation in normal lab processes and bodily function. Another reason that ER visits can often take a long time is the imaging. Now, this is a huge one. For someone who comes in with abdominal pain that requires a CT scan of their abdomen, that already alone is going to take several hours, and I usually tell my patients up front that, just to set expectations from the start of the encounter. Patients are getting into the habit of asking this nowadays, I think just because of the growing wait times, especially at my shop, and especially around the holidays, as it's just the mid-Memorial Day weekend and we were very, very busy. And so patients are often asking how long things are going to take. But for CAT scans, patients that require CAT scans, I usually tell them 2 to 3 hours at a minimum. And the reason that is because CAT scans, generally, if they require IV contrast, we need to wait for your kidney function to return in order to make sure that your kidney function is stable and normal and able to receive the IV contrast, although there may not really be a risk of IV contrast with kidney function, but that's another video. The next point is that once the CAT scan is ordered, you have to get in the queue. You, along with all the other patients who are going to be level 3s or level 2s, they unfortunately just have to be in the queue. If patients are level 1, they require emergent imaging, they just get to bump the line, and that's just the way that it is in the emergency department, right? We prioritize the sickest patients first. And again, this goes back to the triage system when you came in about whether you're level 1, 2, 3, 4, or 5. Patients that require CT scans also need transport. There's more than just the CAT scan getting done. It's the blood work, it's the results of the blood work, and it's the transportation, and then it's the scanning itself, which actually, the scanning itself is the quickest part. I mean, you can get a CAT scan of the head done in 2 minutes flat, but for the patient to get over there, they have to be set up by transport, and national shortages, and all hospitals across the country are facing difficulties with transporting patients, getting nursing care, and even getting physicians in some places, which can again account for long wait times. Being short-staffed in the ER is never a good thing, and unfortunately, that's just the reality of working the ER oftentimes. So after you get your CAT scan, here's another long wait. Who's going to interpret it? I, as an emergency physician, can do basic interpretation of x-rays, some ultrasounds, but I'm formally not trained in interpreting CAT scans. I can look at them and sometimes pick out obvious things, but my judgment really should be based on a true radiologist interpretation of it. The radiologists are the specialty that interpret images. They're the ones that read x-rays, CAT scans, ultrasounds, MRIs, you name it. The radiologist is the one that's going to look at those images and interpret whether or not there are findings, what is the acuity of those findings, and then it's on me to determine whether those findings are clinically significant. And so there is, again, a little bit of brain work that goes on here between myself and the radiologist. Sometimes we'll have to even talk to discuss what's going on with this patient and whether these findings are meaningful. So again, that takes time. And just for an example, at my shop, I just worked last night, and it took about 1 to 2 hours for each CAT scan to get a result. From the time the images were already completed to the time that the radiologist was able to read, interpret, and post the results was between 1 and 2 hours. So if you're taking that into account, that's, again, multiple hours stay in the emergency department. Great, that's my video. Thank you so much. I really hope you enjoyed it. And if you have any comments, please leave them in the comment section below. This is the first part of a many video series I hope to continue to do, talking about what we do in the ER so that patients, you guys, and I can be on the same page about what it is we're doing. That's all.